So with that, let me introduce the next speaker of our very own, Dr. Wainberg, whom you have met. Some of you are his patient. And he's really the leader of our group here for the GI oncology program. Will tell us now about the advances of chemotherapy. Zev?
Thank you. So I also want to thank Augie and Dr. Go for having me. First of all, I'm a clinician here, a clinical oncologist who sees a lot of the patients with pancreatic cancer here. And it really is, first of all, we're very grateful for all the advocacy that the Hirschberg Foundation does. And I appreciate being invited. But more importantly, it's so inspiring as a clinical oncologist to see all their patients, see many patients and their families who are really, they're the true heroes here. And obviously, surpassing many of our worst expectations, and it's so great to see everybody here today. So I'm going to try my best not to reiterate too many of the comments of Professor Mehta, and I'll try to come at it from a different angle, which is where we come at it at the clinical side and how we try to improve outcomes for patients. And like Dr. Mehta said, the majority of the talk will focus on true pancreatic ductal adenocarcinoma, although in the last couple of years, there's been great advances in this other subset of pancreatic neuroendocrine tumors with new imaging ways and even new treatments coming up. So we've made progress there as well. And not to belabor the point too much, but this is a disease which is certainly on the rise, which is rapidly growing, both in incidence and in the expected number of patients who will unfortunately pass away from pancreatic cancer, and this is something we need to better understand, as Dr. Mehta suggested. So 20 years ago, there were no treatments approved for pancreatic cancer at all. There was no chemotherapy that was approved. There were no drugs approved. It was really the dark ages. Beginning in the mid to late 90s, gemcitabine was approved, and in fact, still the mainstay chemotherapy for this disease. And then over the last 20 years, there have been a lot of unfortunate results in pancreatic cancer in which the treatments to improve on gemcitabine were failures. Fortunately, about 5-6 years ago, there were several combination chemotherapy regimens which were shown to improve survival. They're referred to here as FOLFIRINOX and nab-paclitaxel gemcitabine, and those two now are considered what we would regard as the mainstay chemotherapy treatments for pancreatic cancer. And both of them come with their pros and cons. FOLFIRINOX is an aggressive treatment regimen which has to be taken very seriously. A lot of patients have side effects, as with any chemotherapy, and monitoring and careful patient selection is critical. Gemcitabine and nab-paclitaxel has perhaps less of a survival advantage, but perhaps has less toxicity. So when we look at chemotherapy and how to determine the right regimen, you have to look at the patient and you have to talk to the patient about what they can expect, what are the side effects that we can expect, and how to deal with that is a very individual thing. We've also learned over the last 20 years that in pancreatic cancer, perhaps the best use of these drugs is not after the cancer has already spread or after surgery, but in fact trying to use these drugs in many respects before surgery. And Tim Donahue gave me these slides, who's one of our surgeons here in the audience, and the UCLA experience, and through Dr. Hines, Dr. Donahue, Dr. Reber, and others, has been to really move these drugs earlier and earlier in the patient's lifespan, which means to give these drugs as opposed to after surgery, try to introduce these drugs earlier on, and that's been one of the great things that's come out of the UCLA program, and an emphasis on this, and has led to, in my opinion, much better outcomes. So we try to move these drugs not just in the locally advanced or late stages, but also in the potentially resectable, what's called borderline resectable, or locally advanced, and of course, ultimately to get to surgery. We recognize, as medical oncologists, that surgery is the only way, for the most part, that we're going to get rid of the cancer, but we also recognize that surgery by itself is insufficient, which is that if we regard this disease as a true systemic problem, which we all think it is, surgery by itself is not going to cure patients alone, and every patient at some point in time, for better or for worse, is looking at some systemic therapy, which includes chemotherapy. We also recognize that there is no doubt that high-experienced surgeons and high-experienced hospitals have better outcomes with these cancers, which is why we really are proud of the IPU that we have here at UCLA, which is a very high-volume center, which is driven on both having high references from all over Southern California and throughout California in an effort to improve outcomes. So we know that we've gotten better at dosing with chemotherapy because over the last 20 years, the chemotherapy, the way we dose it, the way we handle the side effects of patients has gotten much improved. And here, this is just a quick slide showing that, in fact, we're able to get patients chemotherapy safely before surgery, get them to surgery with no difference in surgical outcomes, no difference in side effects, and more, again, recognizing the importance of giving the treatment up front in an effort to try to reduce the number of cancer cells that are circulating through the bloodstream or through the lymph nodes and try to get that at a minimum before going on to surgery. So at most centers, this has not been advocated to the extent that it is here, and certainly at UCLA, this is a very popular thing, and in my opinion, is one of the main reasons why the outcomes here are so favorable. And this was actually reported initially by a number of doctors at UCLA going back nearly 20 years, and now has become in vogue, and even I would venture to say at MD Anderson, they do this routinely now. So before, whereas a patient had a big tumor that could not be resected because of local vein involvement and local organ involvement with aggressive combination chemotherapy, here's just an example, we can shrink the tumor down, spare some of the veins, and then a patient can end up having a curative surgery. So I'm going to spend a few minutes talking about what's coming, and so I do a lot of the clinical research here at UCLA, which is investigating some new drugs in patients and trying to find new ways to move the field forward. To some extent, the era of chemotherapy is coming to an end, and with respect to new drug development is not, by and large, taking place on developing classical cytotoxic chemotherapy. The focus is on other therapies, so we'll go over that. There is still some recognition that in 2017, the only treatments that work for pancreatic cancer that are proven are cytotoxic chemotherapies, that by and large, for this cancer, which is a very difficult cancer, we all recognize, the only drugs that are really effective here are the true cytotoxics, which means cytotoxic refers to chemotherapy. It's drugs that kill rapidly dividing cells. And there is some emphasis in the last few years to try to improve on the existing drugs. Here's one example of a drug that is taking an old chemotherapy drug called irinotecan, basically putting it in a different mechanism and a different delivery and trying to get access to the cancer cells in a higher volume. And they have, in fact, this drug got approved for pancreatic cancer in the last couple of years by the FDA. And the idea is here, if you repackage it in a better, more stable liposome, and then you can get better actual drug delivery into the tumor cells. And in fact, we're doing a trial here at UCLA looking at this drug in combination with standard chemotherapy, seeing if we can improve outcomes and seeing if we can reduce toxicity. The other area, though, is targeted therapies. And when we talk about targeted therapies, we think about drugs that are blocking specific proteins. So as opposed to cytotoxic chemotherapy, which kills all cells, targeted therapies have the advantage of blocking a specific protein or a specific gene that's involved and presumably relevant to the growth of that tumor. Dr. Matra talked about KRAS being the ultimate gene that we one day hope to have a targeted therapy against. For now, we don't have that, but we have other targeted therapies that are being discovered. And what we recognize is that those drugs are out there, and we're starting to understand them more, and they're being used more and more. Now, drug development today, in 2017, no companies are really developing new chemotherapy drugs, where the emphasis is on these two pathways: targeted therapies, which, as I mentioned, is blocking specific proteins relevant to the tumor growth, and immunotherapy, which is, as Dr. Mehta mentioned, a way in which to manipulate the immune system in some way, shape, or form to attack the cancer, as opposed to drugs that will attack the cancer cell directly. These drugs, immunotherapy, are manipulations to take our own T cells, our own innate immune system, and use them through manipulations to attack the cancer, which don't recognize, unfortunately, pancreatic cancer by itself. So this is where drug development is in this era, through both pharmaceutical industry, through grants, through the government. This is where we are, and we're trying to get more and more of these drugs in patients with pancreatic cancer that go through this formal testing process. So here you see a whole host of targets that have been determined by the scientists to be relevant in this disease, in that they're either highly expressed, which means the genes are found to a higher extent in pancreatic cancer than others, that are able to be drugged, which means they can take a drug and they can block the expression of that protein in the patient's tumor. And they're all being tested in various stages and iterations, going from phase 1 clinical trials through phase 2, all the way up to phase 3. All of these drugs are now being tested in some way, shape, or form, and many of them here in pancreatic cancer. So immunotherapy, which is, we'll talk a few minutes about immunotherapy, because as we all know, that's in vogue right now as the premier way in which drugs are being developed, have the promise, we hope, of changing what's called the tail of the curve, which is that with chemotherapy, we know that the majority of patients eventually will have severe toxicity, will have severe side effects, and will not be able to continue to sustain the benefits that they may have had in the beginning, as opposed to immunotherapy, which is recognition that there is this group of patients in what's called the tail of the curve, in which, because of the way the immune system can be manipulated, if we can identify those patients, and they've been identified now, as Dr. Mehta said, in melanoma and lung cancer, bladder cancer, kidney cancer, every few months there's a new cancer in which we know that the immunotherapy plays an important role. Pancreatic cancer is still yet to come, but the promise is that we can not just identify patients in whom these drugs are temporarily effective, but also move the tail of the curve. So you can identify some patients in whom long-term survivorship is essentially becomes a much more common thing in diseases like pancreatic cancer and others. And we're not there yet, but as Dr. Mehta suggested, that's probably coming in the next few years. So one of the fundamental problems with pancreatic cancer, as also Dr. Mehta talked about, is that it's generally thought to be an immunosuppressive disease, which means our ability to stimulate the immune system and get the T cells to get into the cancer cells is limited for lots of reasons that scientists are working on, trying to understand that these single-agent drugs like PD-1 inhibitors that we've heard about, or CTLA-4 inhibitors, they're not effective. And one of the main reasons they're not effective is because you can unleash all the T cells you want. If they don't have access into the cancer cells where the cancer is, it's not going to manifest in improved clinical outcomes. So there are multiple strategies. Here, one of our strategies is actually to take chemotherapy and combine it with immunotherapy. So combination strategies, and try to, in essence, reduce the number of cells that are sensitive to the, increase the number of cells that are sensitive to immunotherapy by decreasing what's called the bulk tumor volume with chemotherapy. So harnessing the power of T cells is really the goal of immunotherapy. There are lots of ways to do this. Dr. Mehta touched on CTLA-4, PD-1. These are checkpoint inhibitors, in which these are drugs that are given intravenously that essentially trick the immune system into being unleashed. There are other much more aggressive ways to stimulate the immune system through things called adoptive T cell therapy, chimeric antigen receptor therapy. These are being done primarily in lymphomas and leukemias, because that's where the science has proven to be effective. But these are much more aggressive ways in which the patient's cells are taken out of their body intravenously. Their T cells are manipulated to recognize the pancreatic cancer cells as foreign, or any cancer cells as foreign, and then being reintroduced. And it's a sort of an individual roadmap to how to treat cancer. And this has now become used more and more in lymphomas and leukemias, and in fact is quickly, early results showing some of these are curing patients with some of these cancers. In pancreatic cancer, we haven't yet made it to that threshold. We simply don't know yet how to manipulate the T cells through either chimeric antigen receptors or other adoptive T cell strategies into recognizing some of the cancer cells or being able to get into the cancer cells. One of the ways that Dr. Mehta suggested is through KRAS, and in fact, some of the very early preclinical research is suggesting that through either adoptive T cell transfer to recognize KRAS as a foreign gene, you can go ahead and think about this strategy. But these take years and years to develop and are still in their infancy in many respects. So there's lots of examples. Here at UCLA, we've got several trials looking at vaccine therapies, immune checkpoint inhibitors, pilot studies looking at different immune iterations, not all done through pancreatic cancer, but open to all patients. And there's a lot of research going on. It's really, in many ways, a very exciting time to participate in this clinical research. I'll skip this real fast. Here we have a clinical trial at UCLA, which is, for example, investigating the combination of chemotherapy with IL-10, which is another way to stimulate immune responses. So we're hopeful and optimistic that as we develop more and more better preclinical data to support this, that will translate into effectiveness in the clinic. Along with this, we recognize that there's a group of patients that are not going to benefit. So part and parcel of doing clinical research is being very accurate with respect to which patients we're looking at, trying to be thorough about it, and collecting the data both on the tissue and on the blood, so we can then go back and say, okay, it didn't work in these patients and here's why, or it did work in these patients and here's why. So we look at the who benefits subtype very carefully when we do clinical research. So I'll just finish up with a couple more slides. The topic of stroma and immunity was also touched on by Dr. Mehta, and pancreatic cancer is pretty unique in that it has a very rich stroma. In many respects, a lot of cancers don't have that problem, which means that there's this group of cells that, again, he described the oatmeal and the raisins, and that's the analogy we use, that the drugs simply don't get access to the cancer cells because of the nature of that organ. The nature of that organ is such that there are these cells that are very resistant to drug delivery, and they're called stromal cells. And a lot of emphasis has been placed on attacking the stroma and manipulating it in such a way to allow drugs to have better access to the cancer cells. And there's, again, a whole host of ways in which that can be done through immune cell stimulators or through drugs that inhibit the stroma directly. One of those that has been very popular and has now led to what's called a phase 3 randomized trial is because of a protein called hyaluronan, which is a highly overexpressed protein in pancreatic cancer, and about a third or 30 to 40% of pancreatic cancer have high expression of this protein, which is a very important protein in the ability of the cell to restrict drug delivery to the cancer cell. So there's been a drug that's been developed to block that protein in patients that overexpress, and the drug is called PEG-PH20, and the preclinical evidence has been very compelling that, in fact, if you use this drug, you can block this group of cancer cells that has elevated expression of that protein. And some of that work is going on, and in fact at UCLA we did some of that work in the early trials, showing that in fact that drug has activity, has some clinical benefit when combined with chemotherapy. And we're doing a trial now, which is just opened at UCLA, which is called a phase 3 randomized trial, which is going to interrogate this question in patients who have high elevations of this protein. They're going to get chemotherapy plus this new drug, and we'll see if obviously it's meaningful. Now, biomarkers, and I'm not going to get into this, Dr. Matra also did, and this is very challenging in pancreatic cancer. And one of the challenges here is that the tumors that we get, especially if they're found in late stages of the disease, are very small, and sometimes we're not able to do proper biomarker interrogation studies on this. Now, this is changing rapidly, because what we see and what we know now is that sometimes a blood sample can give you as much or near as much genetic information as taking a biopsy from the tumor. And so what we're starting to do is direct our therapies based on biomarkers that are found in the blood, and these are some of them that are looking at right now. So here's a list, for example, of select drugs that we're evaluating at UCLA. We've got a whole host of clinical trials for patients. Some of them are selected for patients who have the target. For example, BRCA 1 and 2. If you have one of those, we have PARP inhibitors, which are very effective for patients with BRCA-associated cancers, be they breast, ovarian, pancreas, or prostate. We've got drugs that block these tumors, and in fact, in the last 10 years, as Dr. Matra said, there's been a huge surge of interest in PARP inhibitors as a therapeutic drug for patients with BRCA mutations. Probably we should be doing a better job as a field testing patients to see if they have these mutations. There's really no harm anymore. It's what used to be a couple $1,000s is now a couple $100 sometimes to find the answers to whether you have a specific genetic mutation. We have another rare subtype called BRAF, which is exceedingly rare. We've got trials for them. We've got trials with combination of chemotherapy, as I mentioned, if you have elevations of certain proteins. And we've got a number of immunotherapy trials which are trying to find a home for immunotherapy in pancreatic cancer, which is, as we've all talked about, a significant challenge. So we've got a lot of hope. We've got lots of reasons to be optimistic in this field, in my opinion. The future is quite bright. We know that we've got a lot of work to do, but the understanding scientifically is better than it's ever been. The cost of doing these studies has decreased substantially in the last 20 years, so what used to be a very costly endeavor to collect patients' tumors is now collected on things like circulating tumor DNA. In the next 10 years, we're probably going to see a big surge in changing the way we think about cancer, because a lot of the technology that's improving is finding the biomarker in the blood, as I mentioned, finding the circulating tumor DNA in the blood to be just as good in many cancers as it is in the tissue. And in an area like pancreatic cancer, there's no better example of a field where that would be a huge surge for research, is identifying biomarkers in the blood. And again, finally, another reason to be optimistic is for work like the Hirschberg Foundation and others, which is really improving advocacy and recognition that we need more foundation support, we need more governmental support to improve outcomes for this disease. So I want to thank you very much for your attention. It's really a pleasure to be here, a pleasure to be part of a wonderful collaborating group like we have at this institution, and thank you.